there are differences in how men and women process pain. It appears with women, sometimes the areas of the brain that are more tied to emotion and thought become more active. Nobody really knows why, but there was an interesting paper out about a year ago that showed that women's actual nociceptors, the actual little receptors that detect pain, are different than they are in men. And so I thought that was really intriguing. So this is something that we are learning more and more about. But without research looking at sex differences, we'll never know for sure.
When it comes to pain, women feel more of it. Women's pain is different. Our hormones, our immune systems, even our brain chemistry. In this episode, we're digging into the science of female pain, from endometriosis to migraines, and why estrogen might actually turn down your body's natural pain relief. Dr. Afton Hassett is a clinical psychologist, leading researcher at the University of Michigan, and author of the book Chronic Pain Reset. She studies how emotions, mindset, and resilience influence chronic pain. Dr. Megan Steele is a doctor of physical therapy, chronic pain specialist, and is pursuing a PhD in rehabilitation and movement science. Dr. Elora Midavaine is a neuroscientist at UCSF, studying how hormones and immune cells interact to control pain. Welcome to the show.
Thank you for having us.
Thank you.
Dr. Hassett, I'll start with you. You are a leader in resilience and pain research. Tell us how this became your specialty in the first place.
Oh, well, first of all, thank you for having me here. It's such a delight to talk to your audience and meet with all of you and tell you a little bit about what we think about chronic pain. And in the context of resilience, I got here quite by surprise. I actually was very interested in depression and negative thoughts as they pertain to pain, and I wrote my dissertation on it. And when I got my results, I soon learned that negative emotions did not very well explain the pain of most people. And as a matter of fact, about 35% of my patient population that I studied with chronic pain was incredibly well adjusted, incredibly resilient, with no history of depression or anxiety. And I just became fascinated. Who are these people who are uniquely resilient? Because not only do they have less pain, they also had better functioning and better quality of life. So that's kind of how I found myself there.
Okay, I can't wait to learn more about this. Dr. Steele, you are a renowned physical therapist specializing in chronic pain. What brought you into this field?
So as a physical therapist, we all have a certain success rate. And what I found was that I wasn't having 100% success with the patients that I was working with. And I thought there must be something else here. So after graduating with my doctorate, I pursued osteopathic visceral manipulation, which is working through the visceral system and how it connects to the musculoskeletal system. And I started having improved outcomes, but still not 100%. And the research in the visceral system is really lacking. And so when you talk to other professions about it, they say things like, oh, that's not really a thing. And the visceral system and the musculoskeletal system don't connect. And we're very biased as physical therapists to the musculoskeletal system. Mm-hmm. So I said, all right, I'll go get a PhD and prove it. And throughout the course of my PhD, which is in its 5th year, not much to show for it yet, but here or there, I've learned that really there's such a broad understanding of pain, and it's not just the musculoskeletal system, it's not just the visceral system, it's the biology, it's the psychology, and the social factors as well. So
fascinating. Dr. Midavaine, you primarily study sex differences when it comes to chronic pain and pain perception, but previously you were in cancer research. So why this shift?
That's a great question. Actually, when I started my graduate studies, I was working on bone cancer pain, so a type of pain that is really hard to manage. And I was trying to develop that new drug against bone cancer pain. And no matter how I tried testing this drug, how I administer it, how long I waited after administration, it never worked. And my grad school PI always insisted, no, it should work. It should really work. And I was a little bit desperate, testing, and nothing ever worked. Until one day I went to see him and I told him, you know what? I think I've tried everything, but I have a gut feeling that I really would love to test. So I was working on bone cancer pain that arises from breast metastasis. So I was working only on females. So I told him, I would really like to try testing my drugs on males. I feel like maybe there's something there that is different between the sexes. And I tested the drug in males, and it was beautifully analgesic. So from that moment, I just got fascinated with sex differences and pain. So I totally switched from cancer to just sex differences.
All of you work in pain and chronic pain. What are the gender gaps that we have found when it comes to pain and pain treatment?
That's such a great question. There's so many gender gaps, almost like if women and men were two different biological systems. Honestly, women have such a much greater prevalence of chronic pain condition. They have increased pain sensitivity, less pain tolerance. And now that we start to investigate the molecular mechanism, how the biology of pain happens, we just realize that those are two different individuals, two different pathways that transmit pain. So we really have to delve into those differences to fully understand why females have so much more pain.
And I'm curious how each of your fields and areas of specialty have understood women's chronic pain over time. Because obviously these gaps exist, but they haven't been sort of paid a lot of attention to. And so could each of you just kind of take this question and talk a little bit about the evolution and our understanding of women's pain in particular?
Sure. From my perspective, as a pain science researcher, the numbers tell us that about 70% of the people that suffer from chronic pain are women. And so it's significantly biased towards women. And when we think about the US population, it's about 20% or 1 in 5 that suffer from chronic pain. Wow. Women are most often diagnosed at midlife or somewhere around the hormonal change of menopause. We don't exactly know 100% why yet. There does seem to be a hormonal component, and there are signs that point to that. Things like women are most often diagnosed around that midlife period, and men and women have similar pain thresholds after menopause and before puberty, but not in between. Women also demonstrate different pain tolerances throughout their menstrual cycle. And so that's why my research focuses on women as well, because up until the 1990s, women were not required to be included in these research studies. And that's where a lot of our lack of knowledge comes from.
And until very recently, we didn't even include females in preclinical research. So on research that is aimed at investigating the mechanism of pain in rodents, we only use males. So all our understanding has been based on males. And just now, after I think it was in 2016 that the NIH required that research be performed in both sexes, that we realized that, oh, we've missed a lot.
Yeah, and from what we've learned from other episodes of this show, often researchers didn't want to test on female rodents because they had cycles, because it was like, oh, that'll make it too complicated or too complex. So yeah, exactly. It's wild when the cycle could actually be a major factor in so many of the investigative questions that we have. Dr. Hassett, let's establish a baseline with you. Is there such thing as healthy pain or normal pain?
Yes, there is. I mean, people who do not have pain receptors do not live very long. You have to have a system that keeps you safe, and so we avoid many dangerous, exposures because we know it's going to be painful. So that's healthy pain. Acute pain occurs when we have surgery, and that's important too. That tells us, not to stand up too quickly. We might tear our sutures. That's good, kind of healthy pain that preserves the organism. Whereas chronic pain often doesn't serve a purpose depending on the particular condition. So we understand that many people who have inflammatory conditions like rheumatoid arthritis or other autoimmune disease, often once that inflammatory pain is treated that's specific to the autoimmune disease, there's still remnant pain. And that pain often is not informative at all. And so that's, when we want to try and treat that type of pain, we refer to it as nosoplastic pain, meaning it's pain that is driven primarily by the brain. And so it's a condition where the brain is now tuned to be more hypersensitive to input. So if you have a little bit of pain, the brain perceives it as much greater. This is something that we see frequently in fibromyalgia. And we know this by neuroscience using fMRI neuroimaging to understand what the brain is doing with pain.
Why don't we stay on you? Could you talk through what's happening on a chemical level when our bodies are feeling pain?
Yeah, so when we actually have something hurt us and our fingers, there's a little nociceptor that is going to send the message right up to the brain. The brain says, oh, that's pain, and then creates pain. Another thing that happens, though, is there's not just one part of the brain that perceives pain. Pain is processed by many, many areas of the brain and many networks. And these are all interconnected. And often they're the same areas and networks that process thoughts and emotions. So that helps us understand how it is when we get very, very frightened and we experience pain, that the pain feels worse, or when we're laughing really hard, the pain feels better, that we actually do have some windows to influence how the actual physiological experience of pain.
Okay. Dr. Hassett just mentioned fibromyalgia. What are some other common pain diagnoses in women?
A lot of common pain diagnoses in women, things like frozen shoulder, arthritis, chronic inflammatory diseases. We think of fibromyalgia and kind of the myalgias as kind of an umbrella term for pain. But when people come into my practice, they're diagnosed with neck pain, low back pain, shoulder pain, these types of issues.
I noticed you didn't mention endometriosis, so we'd love to know what's happening in the body that's causing endometriosis or menstrual pain.
Sure. Menstrual pain or dysmenorrhea and endometriosis are two separate things. Oftentimes, we think about dysmenorrhea as primary or secondary. So primary dysmenorrhea has no underlying cause, similar to something like IBS, where we think of it as more of a functional problem, but we don't see anything on scans, X-rays, MRI, CTs, those types of things. Whereas secondary dysmenorrhea is sometimes caused by fibroids or things like endometriosis, which is when the endometrial lining of the uterus is outside of the uterine wall. And that can lead to pain and discomfort, inflammation, and sometimes even nerve growth.
All right, Dr. Midavaine, what about migraines? What's happening in our body when we get migraines?
Migraine is an interesting one. Migraine often happen more frequently in women than men, and they tend to happen just before periods. And this is caused by the drop in sex hormone, specifically estrogen, that makes the neurons in the brain more sensitive, more excitable. So what happens with those neurons is that they will release a lot of neurotransmitter in the brain, neurotransmitter that signal pain, and those will go activate the nociceptor or the neurons that sense pain, and that will induce the migraine in the woman.
And just jumping back to the male-female differences, do we know what explains the higher prevalence in chronic pain conditions such as migraines in women versus men?
There's so many factors that contribute to this disparity. Sex hormone is a huge one. We know that estrogen will synthesize neurons, but we know that it will also increase molecules that sense pain. It will decrease our pain modulation system in the body. So a lot of factors that are at play. There's also genetic differences. So women have two X chromosomes, men have X and Y. We know that there are different genes that are expressed on each of those chromosomes. So this also plays a role. And some genetic differences in some genes that are involved in pain modulation have a much greater impact in women than in men in inducing chronic pain conditions.
And Dr. Hassett, do we know whether in neuroimaging that brain regions in males versus females light up differently when we experience pain?
There is good evidence that there are differences in how men and women process pain. Different regions of the brain become responsive. It appears with women, sometimes the areas of the brain that are more tied to emotion and thought become more active. It's a little different with men. Nobody really knows why, but there was an interesting paper out about a year ago out of, I believe, Arizona State University that showed that women's actual nociceptors, the actual little receptors that detect pain, are different than they are in men. And so I thought that was really intriguing. So this is something that we are learning more and more about. But without research looking at sex differences, we'll never know for sure.
Right. Dr. Steele, what about changes in the brain when it comes to chronic pain versus acute pain?
This has really come to light over the last 10 to 15 years with the advent of fMRIs. So an fMRI is something where they put someone in an MRI machine, give them a stimulus, and see what's happening in their brain in real time. And when we look at people who have acute pain, we see their somatosensory areas of their brain light up, or the outside of their brain. And when people have had pain for a long time, and typically we characterize chronic pain as having gone on for 3 months or more, which isn't always the most accurate, but that tends to be how we define it. When you give those people a pain stimulus or you remind them of their pain, the areas of their brain that light up deal with memory and emotion. And so that tells us that acute pain and chronic pain really are two different animals. And when we're thinking about acute pain, we're thinking about tissue damage and nociception. And when we think about chronic pain, we really need to be thinking about threat detection.
Dr. Midavaine, you were the lead author on a groundbreaking study that found that estrogen and progesterone actually help produce natural opioids in the body. Can you break down this research and the significance of what you found?
Absolutely. So we found that in women, there's a pain control mechanism that exists that does not exist in the males. So we found that there are immune cells located in the protective layers of the spinal cord that will release endogenous opioids in the females that will tone down the pain signals before they reach the brain, whereas this mechanism is not involved in the male. And we found that if we remove sex hormones in the female, that pain mechanism is not effective anymore. And when we give them estrogen or progesterone alone, nothing happens. But we really need a combination of those two hormones to kick in that system, to activate the immune system, to release those endogenous opioids. And it all depends on the dose of estrogen. So low estrogen will tend to sensitize neurons, tend to downregulate the opioid system, whereas high estrogen level really kicks in that pain control system by our endogenous opioids.
And is it just about the dose or the amount of estrogen, or is it kind of the fluctuation too? Because doesn't that play a role in some of these?
Absolutely. That's a great point. We need a long-lasting dose of high estrogen to kick in that system more effectively.
Okay.
And that can relate to pregnancy. We know that sex hormone gradually increase during pregnancy. And there is a fascinating phenomenon that happens in those pregnant women where a pre-existing pain condition will disappear during pregnancy. One that is the most known is migraines, as we mentioned earlier. So some women during pregnancy will see a complete disappearance of their migraine.
Okay.
And as soon as they deliver, their migraines will just come back. And this is caused by the mechanism that we identified in our paper that involves immune cells that release endogenous opioids really close to the spinal cord and the pain-sensing neurons.
Have we talked about all the different ways that estrogen could have an impact on female pain perception, or are there other ones that you want to talk about? Other ways that estrogen have an impact?
Well, the fluctuation, as you mentioned, really is detrimental in pain processing. So the rapid up and downs, the cyclic levels of estrogen tend to make nociceptors, so pain-sensing neurons, more sensitive, more excitable. But when we have long-lasting high level of estrogen, then we can kick in our pain control system. Endogenous opioids increase, but we also have the receptors for those endogenous opioids that increase with high estrogen. So estrogen play on pain level at multiple levels.
Does this give us any answers then, Dr. Steele, about treating menopause? and pain during menopause?
Absolutely. And I think there's been a really important increase in the awareness and understanding of these changes and how they affect women.
We're just talking about perimenopause so much more in culture, I think.
Which I think is such a great and important topic to highlight, because all women will go through perimenopause if they make it to that age. Yeah. So as Dr. Midavaine said earlier, it's not the level of estrogen, it's these rapid swings. And that's what we find as women go into menopause, is they experience these rapid swings in hormones. So some women, most women will have a significant drop in their estrogen around menopause. And now they're terming it the musculoskeletal syndrome of menopause. That has to do with all of the physical manifestations therein. Yeah. And there's some research going into that as well, which is really exciting. Some women will have a significant increase in estrogen and also have more pain. So it's not exactly clear. We do know that estrogen plays a role in inflammatory processes. So lower levels of estrogen contribute to higher levels of inflammation in the body, which can contribute to things like joint pain and stiffness. But we don't have complete answers on all of those questions yet.
This brings us back to frozen shoulder and why frozen shoulder is a menopause-specific condition, or tends to be.
Yeah, it tends to be menopause specific. And so it really is gender specific and menopause specific. And there again, we don't know the exact underlying mechanism, but we do know that almost all of the 90% of women that receive a diagnosis of frozen shoulder happen around that menopause, perimenopause age.
What exactly is frozen shoulder? How do I know whether I'm getting it or if I have it? Or
that's a good question. So frozen shoulder can mimic other things, but ultimately it's a significant decrease in your range of motion of your shoulder. And you would notice it because you didn't have an injury, like a fall on an outstretched arm or a car accident or things like that. You would just start to notice that your shoulder became more and more stiff, and you would have more and more trouble moving it, especially in this motion, this external rotation direction. And over time, it would get more and more stiff to the point that you may not be able to do things like hook your bra or wash your hair.
Wow. Dr. Midavaine, we haven't spoken about progesterone yet. And so how does progesterone play a role in our pain response?
Progesterone is very much less known than estrogen. Yes. There's much less research, but we know that it tends to be anti-inflammatory. So it would have some anti-nociceptive, anti-pain properties. But again, depending on the dose, makes a big difference.
Okay. Dr. Hassett, we'll move to the whole body and how the brain and the body are all connected. If someone is doubtful about the relationship between psychology and pain, what do you say to them?
I would understand that. If I had chronic pain and I went in to see somebody for care and they wanted to send me to a psychologist, I'd be very put out. But what we understand is that psychology brings a lot of options for not only dampening the experience of pain, but how to better function with chronic pain. So there is a really tight tie. One of the things that we observe is the higher rates of anxiety and depression in people who have chronic pain. That can be a combination of things. That can be kind of the same neurochemicals, neurotransmitters, and hormones. Or it could also be what it's like to live with chronic pain, that it can be really disruptive to one's life. They also look like they both overlap in genetics. So there really is this close tie. For a psychologist, what's really meaningful to us is it's so important to treat the depression and anxiety. And often when we do, the pain gets better. And also, conversely, when the pain gets better, often the depression and anxiety do. So the tie is very, very tight. That's just kind of one example, but there are many.
And it's interesting how the pharmacology of depression and chronic pain really overlaps too. Yes. As Doctor mentioned, similar brain regions are involved, similar neurotransmitters. So we know that mood regulation involves serotonin, noradrenaline, but so is pain control. So if you have a decrease in those neurotransmitters that will lead to depression, they might also lead to chronic pain.
Yeah.
And antidepressants that are used to treat depression are also used to treat chronic pain. So antidepressant will increase the level of serotonin, noradrenaline, and it will decrease pain and also decrease depression.
Dr. Hassett, what has your research found is the relationship between psychological changes on pain symptoms? You talked a little bit about this earlier, but why don't we just set the table?
Yeah, it's incredibly powerful. We are really kind of in the dawn of some new behavioral therapies that help us intervene with really often long-term chronic pain by, as Dr. Steele was mentioning, the threat detection system, by these interventions that go right at mitigating the pain due to kind of an overactive threat detection. And so that has really, more than anything, kind of revolutionized this thought that pain is so closely tied to kind of our emotional and our thought states. Not meaning that the pain is in anyone's head, but that what we think and what we experience profoundly impacts the experience of pain. And that opens the door to us being able to use these kind of novel behavioral treatments, mostly through kind of exposure therapy, just having people in a different context do some of the movements that they used to cause pain and cause fear. And we deactivate kind of that fear response, and people find themselves able now to do these movements. So it's a much more kind of complex, but it is a little bit of a miracle. We were conducting, I believe, 5 different studies looking at pain reprocessing therapy and emotional exposure therapies to really quite effectively eliminate pain in some of our patients.
Can you explain why, if given this connection or the emerging research on this connection, that the fields of psychology and then pain management tend to be siloed or studied separately rather than connected?
Yeah. Well, we didn't start here probably about 20 years ago. The belief that an interdisciplinary approach to pain was the key, right? So you would have a physician, you'd have perhaps a nurse, you would have a physical therapist, you'd have an occupational therapist, and a psychologist, and everybody working together to treat pain because it is indeed sensory, emotional, and due to cognitive processes. That fell out of favor during the opioid epidemic, and there was this turn to medication only and interventions only, and we, fast forward 20 years, we learned a lot of lessons, and now we're kind of back to this place where we're really focusing again on intervening with a kind of a whole group, with an interdisciplinary team, because of this relationship between emotions, thoughts, and the experience of pain.
And just to go back to something you talked about earlier, it looks like 75% of patients with depression report pain, and then chronic pain triples depression risk.
Yes.
What's the scientific basis for this relationship?
It's multifactorial. We see a genetic component, kind of a familial component too. So it could even be environmental, that people have parents or family members in the household that either model chronic pain or have depression, so it becomes almost a norm.
Mm-hmm.
There are biological, so changes in the brain as well as changes in neuroendocrine systems. So with depression and pain, we see the same disruption in neurotransmitters. I believe it was Dr. Midavaine who was mentioning this before, that we see disruption in serotonin and norepinephrine that impacts not only depression, but it impacts pain processing.
Okay, Dr. Steele, first, what does it mean for pain to be learned or be a learned experience?
That's a good question. So when we talk about associative learning, we think about classical or Pavlovian conditioning.
Okay.
The classic study where the researcher rang a bell and then fed the dogs. Every time he rang the bell, he fed the dogs. Then the dogs began to salivate every time he rang the bell. Mm-hmm. In our lives, that could occur with something like a car accident, having been rear-ended. So if I were rear-ended by a red car, every time I see a red car in my rearview mirror, that might activate my body's protective mechanism, causing my body to sound the alarm of pain.
Can previous experiences of pain, such as a car accident, then train our nervous systems to overreact?
Absolutely. And there are two really critical periods of amygdala development. One is 2 to 3 years old, and then another one is around puberty, 12 to 13 years old.
Okay.
And we need support during those times. So when we're young, we need that support from our parents. And when we're adolescents, we often get that support from our peer group. And what we find is people who've had adverse childhood experiences, they tend more likely to have chronic pain, or they are more likely to experience chronic pain later on in life. And that may be because their nervous system is at a different set point, or it may be because their nervous system has learned over time to respond to less and less stimulus. So, for example, women who have dysmenorrhea or pain during menstruation are twice as likely to suffer from chronic pelvic pain later on in life.
Why is that, do we think?
So we think part of it is the sensitization of the nervous system. So over time, my nervous system gets better at predicting a response. Our brain and our nervous system are prediction-making machines. And so sometimes my nervous system will take a little bit of information and then extrapolate a larger response from that.
Yeah. So, but then later in life, it can be maladaptive because then you're just feeling pain all the time.
Absolutely. Okay. I start to now experience non-nociceptive stimuli or non-painful stimuli as painful because my nervous system is so sensitized.
And then just to follow up, what's the role of stress here when it comes to chronic pain?
Stress is a significant player in pain. Stress has a tendency to sensitize the nervous system. And when we think about the role of learning in pain, there's the potential of stress states becoming associatively learned and signaling a protective mechanism in the body. Similarly to when you were talking about women experiencing pain after cancer, some of the signaling and the awareness of the body signals, and this is through the interoceptive research that we've learned a lot about this, that level of awareness and hypervigilance about every sensation coming from our body starts to signal our threat detection system, whereas before a cancer diagnosis, I didn't have that level of awareness.
Wow. Do either of you want to add anything when it comes to this question about stress and pain and the role of stress when it comes to our chronic pain?
Seems like...
Oh, Dr. Hassett, go for it. Yeah.
So some other processes we see that are really important to stress is not just kind of the neurobiology of stress, because that is pretty profound, but it's also the behaviors. So when we're stressed, we tend to do things that can make our pain worse. For example, we can be much more tense, but we also tend to not do the things that make us feel better. So when we're stressed, we tend to eat poorly, we don't sleep well, we don't do fun things with our friends, we tend to think more catastrophically, we tend to be more likely to be down and sad. So in many ways, stress can profoundly change how severe someone is experiencing their pain. And most people with chronic pain have an awareness. They'll tell you, oh yeah, when my pain is so much worse when I'm stressed.
Yeah.
What is interesting also is that stress has a duality. So it can either increase pain or decrease pain, depending if it's an acute stress or a chronic stress. If you have a very strong acute stress, you have a bear running after you, you're not going to feel any pain. You break your leg while you're running, you're never going to feel it. Because the amygdala, the area in the brain, one of the areas in the brain that process stress, well, they're going to tell your pain control system, go, we need you right now. Whereas when you have chronic stress, it's going to shut down that pain control system. And that's when you're going to have more and more pain.
So we have some audience questions from the TIA health community that we kind of put a call out for. So any of you can take it and you can build on each other's answers. First question, how should women discuss pain with doctors who dismiss it? Dr. Hassett, do you want to go first?
Yes, this is such an important question because this happens too frequently to women. And I mean, there's a long history of women's pain being dismissed and some pretty dramatic examples. But when it's you in front of that doctor, sometimes it means you need a different doctor because there's almost nothing you can do necessarily to make that physician be empathic to you. Now, if you're stuck, now you're stuck, then you do have to advocate for yourself. And you do have to say, this is my pain, this is important to me, and I would like to form a treatment plan. So this assertiveness is very, very challenging, especially in the face of an authority. But, it is your body and you are your best advocate. So, go for it.
Okay.
And women tend to be prescribed sedatives compared to men being prescribed analgesics. So there is a profound
and
issue.
what's an analgesic?
A drug that controls pain.
Okay.
Yeah, I would add to that, if you are someone who has the opportunity to choose a provider, you might ask them, how do you treat people differently when they have acute pain versus chronic pain? And if you don't like the answer or they don't have a good answer, that may be a signal to choose a different provider.
Okay. All right. A more specific question from the audience. How does stigma around weight add to social stress and influence pain treatment?
Yeah. And again, it breaks my heart. There are so many preconceived notions about people and the assignment of responsibility. Well, if you just lost weight, you wouldn't have so much pain. It's like, if I had less pain, I could exercise and lose weight, right? So again, it is kind of advocating for yourself and being willing to find a physician that can work with you. There is good data that if we can get people moving, it doesn't matter necessarily even the weight. If it's healthy for you to move and you're able to move, getting into a good physical therapy regimen, getting into some gentle exercise is really the best, some of the best treatment that we have for chronic pain, and can be very helpful for people who are also trying to manage their weight.
For all of our listeners and viewers out there, if you could offer one practical takeaway that you hope listeners will walk away with, what would it be?
The one thing I would love for our listeners to take away is that in the case of chronic pain, and even acute pain, but really with chronic pain, because your brain processes emotions, thoughts, and pain using a lot of the same systems, the door is open for you to make a difference. And so that can empower you to know that simple changes that you can make as far as how you think about things, decreasing the stress and stress activation, being able to have some treatment for perhaps if you have some mood concerns or have a lot of negative emotion, can you bring some joy into your life? For cleaning up your relationships, for being with people who are supportive and loving of you as opposed to not. All of these go a long way towards kind of decreasing this overall sense of stress, increasing empowerment, and actually dampening down some of the experience of pain.
Having a positive relationship with your healthcare provider will also help a lot. To find a therapeutic plan that works for you, find different management strategies. So I think that's a big
trusting
one.
your provider.
Absolutely.
Yeah. Okay.
Huge. I would say pain is normal. Pain is a normal human experience, but pain is not a normal state of being. And because our brains are plastic, even if you've had pain for 20 years, you can improve. Your pain can always change. As long as you're breathing oxygen, you can change your pain.
Okay. Final question. What is one shift in either research or clinical practice that could revolutionize how we treat women's pain in the future?
Believe them.
Including females in preclinical research, including females in clinical trials, but also considering sex as a variable in trials so that women and men are analyzed separately to know, well, does that treatment work better in one sex compared to the other, which will be very valuable information for
Such
women.
An important thing to advocate for. Dr. Hassett?
And give people who have chronic pain the tools they need to recover and to do well. And that can come in many forms, but just offer these things to them. So whether it be medication, whether it be a behavioral intervention, whether it be the physical therapy they need, but yes, get these into people's hands because they will use them.
Such useful and actionable takeaways today. Thank you three so much.
Thank you.
Thank you very much.
Before we let you go, I wanted to present you with a thank you gift from Tia Health. You can open it up and see what it is, and Dr. Hassett can find out as well. It's always fun to watch people unwrap their gifts.
It is.
Uh-huh.
I feel like it's a kimono.
Yeah, it's like a kimono. It's a
lovely.
robe. It's a robe that patients at the Tia Health clinics get to wear. So instead of the traditional like papery medical gown, they get to wear these fancy silk robes.
That is
So
so
lovely.
lovely.
Yeah.
Well, thank you so much.
Yeah, thank
You're
you.
welcome. Yeah, wear it around and then you can model it for Dr. Hassett too. We'll kind of, yeah, you have to get in front of the computer here.
Isn't that
Pretty.
beautiful?
Yeah.
The paper.
So comfortable.
So much better
too.
than the paper, right? And then here's Dr. Steele and hers.
Oh, that's awesome.
Pain isn't just a symptom, it's a signal. The way we feel pain is shaped by our hormones, our stress levels, our genetics, and how we're treated when we speak up. I hope you learned something that helps you ask the right questions and manage your pain a little bit better. Big thanks to Dr. Afton Hassett, Dr. Megan Steele, and Dr. Elora Midavaine. Their work and ways to support your own body are linked below. Hit subscribe for more conversations that'll change how you think about your health.